Good morning all. Our session is on primary angle closure disease and an overview. First talk is on pearls in gonioscopy by Dr. Lita George. She's a glaucoma consultant in Tony's High Hospital, Aluva. She did her fellowship in glaucoma from Aravind Tirunelveli.
Very good morning to all. So my topic for discussion today is gonioscopy. It is a fundamental part of the comprehensive eye examination, and the basic purpose is to understand the topography of the anterior chamber angle. It is the gold standard against which all other angle imaging techniques are compared. However, it is one of the most neglected procedures in ophthalmology. In the beginning of the residency, everyone starts doing gonioscopy, find it as a cumbersome and messy procedure and just give up. Actually, with practice, it is a technique which can be easily mastered. The normal angle anatomy begins with the Schwalbe's line and extends up to the root of the iris posteriorly. In between, you have the non-pigmented and pigmented trabecular meshwork, the scleral spur and the ciliary body band. Normally, the light from the angle undergoes total internal reflection. However, a gonio mirror eliminates total internal reflection by replacing the cornea-air interface by a new interface. So the gonioscopy can be indirect or direct. Indirect gonioscopy is the standard OPD examination technique. It is called indirect as the image is inverted, but to be noted, it is not laterally reversed. For the beginners to learn, it is always better to start using lens with flanges, the examples being the Goldman single mirror, the Goldman 2 mirror and 3 mirror lenses. These are also called as the scleral type of lenses. They have got a larger diameter and you need to use a coupling medium. They provide more stability and you will be able to visualize the structures properly. The technique always starts with precautions. It is important that you do gonioscopy in a dark room, and also the slit lamp gratitude height has to be less than 5 millimeter, otherwise there can be pupillar meiosis which can artifactually open up the angle. Examine the lens, see there are no cracks, apply the coupling agent. Take care to avoid bubbles, otherwise bubbles can come in between and obscure your view. Explain the procedure to the patient. Instill a drop of paraffin in both eyes. Place the chin of the patient on the chin rest with the forehead against the forehead band. Separate the upper and lower lids with your thumb and index finger and ask the patient to look up and insert the lens from below. Once you have learned gonioscopy, to make the procedure simpler, you have to switch to 4 mirror lenses, either a Posner, a Sussman or a Zeiss lenses. These lenses are also called as the corneal type of lenses. Here you need not use a coupling agent. You can just instill a drop of paraffin and straight away place the lens. This procedure is more comfortable both for the examiner as well as for the patient, and it is less time consuming. Direct gonioscopy, it is an OT examination technique. Earlier it was mainly used for congenital glaucomas for the procedure of goniotomy, but now with the advent of minimally invasive procedure, there is an emerging interest in direct gonioscopy. Most of the minimally invasive procedures are angle-based surgeries and they require a mastery over the skill of direct gonioscopy. The examples are the Barkin, Scopius and the Swan-Jacob lenses. So while doing gonioscopy, first estimate the width of the angle, see whether it's an closed or an open angle, see the level of iris insertion, look for the profile of the peripheral iris, whether it's a concave, convex or a flat iris. Concave configuration you get in pigment dispersion syndrome following cataract surgery and even in myopes. Convex configuration is the one which you observe in angle closure glaucoma, and in flat iris insertion is noted in plateau iris syndrome. See the degree of trabecular meshwork pigmentation. Hyperpigmented trab you can get in conditions of pigment dispersion, pseudo-exfoliation following cataract surgery, inflammation, etc. In young patients, the trabecular meshwork may not be pigmented, so you can easily misdiagnose it as a closed angle. So always identify the Schwalbe's line using a corneal wedge, and also identify areas of iridotrabecular apposition or synecdoche. If the pigmented trabecular meshwork is not visible without manipulation or indentation in at least 3 quadrants, it is called as an occludable angle. Then you have to do a dynamic gonioscopy, which can either be a manipulation or an indentation gonioscopy. Manipulation gonioscopy is the one which you do with your 2 mirror lenses. Here either you can ask the patient to look towards the mirror or you can tilt the lens towards the angle. Indentation gonioscopy is done with the 4 mirror lenses. Here with the lens you exert an axial pressure in the central cornea which pushes the aqueous to both sides, and in case of appositional closure this opens up the angle. Gonioscopy should be avoided in conditions of acute infections in case of bullae on cornea and in post-traumatic eyes. You have different grading systems like Schaeffer's, Shea's, Pate's, and RP Center. In Schaeffer's, based on the geometric angle width, there are 4 basic grades. Grade 4 and grade 3 are open angles where almost all angle structures are visible, and grade 1 and 0 are closed angles. However, Shea's grading is just the reverse. Here the grade 4 is the most occludable one. So it is better to mention the structure which has been visualized in order to avoid confusion. So now certain clinical scenarios. One confusion you can get is regarding the peripheral anterior synecdoche and iris processes. These iris processes are thin filiform structures. They do not cross the trabecular meshwork and do not obscure the view of the underlying angle structures. As opposed to this, the peripheral anterior synecdoche, they are broad, irregular, hyperpigmented. They cross the trabecular meshwork. They can extend to any level even beyond the Schwalbe's line, and they cause functional obstruction for the aqueous drainage. Plateau iris, here the iris exhibit a flat approach to the angle, and what we see is a sine wave pattern. In pigment dispersion, you can get a uniformly hyperpigmented trap in all the 4 quadrants, which is referred to as the mascara line. There is also a hyperpigmented Schwalbe's known as the Sample-Assays line. In pseudo-exfoliation, there is excessive pigment dispersion. However, the trabecular meshwork is not as uniformly pigmented as in pigment dispersion, and here the pigmentation is more in the inferior angle. You can also get pseudo-exfoliative material in the trabecular meshwork itself. In neovascular glaucoma, you get fine arborizing vessels over the trabecular meshwork. These vessels are branching and fine. As opposed to this, the normal angle vessels, they have got a greater caliber. They are usually single in number. In angle recession, you get a widened ciliary body band. Here it is always advisable to do gonioscopy of the normal eye first, so as to get an idea regarding the width of the ciliary body band, as ciliary body band may be normally visible in myopes. So to conclude, gonioscopy is mandatory in the diagnosis and treatment of glaucoma. To master it, start doing and keep doing. Thank you.
Thank you, Dr. Lita. That was a wonderful presentation on the basic of glaucoma, the gonioscopy. Now I invite Dr. SMITHA. She's a consultant in Little Flower Hospital in the Department of Glaucoma. She'll be presenting the imaging techniques in angle assessment. Can they replace gonioscopy?
Good morning all. My topic is imaging techniques and angle assessment. Can they replace gonioscopy? Anterior segment imaging provides cross-sectional angle picture. It offers an objective method for visualizing the angle and adjacent anatomical structures. It can be done with anterior segment OCT, UBM, pentacam, and ICAM. I am discussing on anterior segment OCT and UBM. With OCT, the axial resolution is 5 microns and lateral resolution is 15 microns, while with UBM, the axial resolution is 25 microns and lateral resolution 50 microns. Coupling medium is needed in case of UBM, and the depth of penetration with OCT is approximately 1 millimeter, while with UBM it is 4 to 5 millimeter. The advantages of OCT are, it's a non-contact method. Patient should be in the sitting position. It is not dependent on the operator's skill. It is useful in children. It has better image resolution, and it can be used for post-surgical assessment. But the main disadvantage is it cannot image structures posterior to iris. With UBM, we can image structures posterior to iris, so we can identify plateau iris, uveal effusion, ciliary body iris, and ciliary body cyst, etc. But the disadvantage is a contact procedure. Patient has to lie down supine, and it requires a skilled operator, and there is risk of corneal injury. It cannot be used in immediate post-surgical period. Advantages of imaging over gonioscopy are, it gives an objective assessment of the anatomic parameters, while gonioscopy cannot do it with good reliability. It can do imaging of anterior segment in eyes with corneal edema and opacity, and factors beyond the angle, that is non-pupillary block mechanism, can be identified. Both qualitative and quantitative assessment can be done with anterior segment imaging. And the most important landmark is the scleral spur. You can identify the scleral spur as a junction, at the junction of the radiotranslucent cornea with radiopaque sclera. It lies at the corneoscleral junction as an inward protrusion. Various parameters can be assessed with this software in these imaging modalities. The most important angle opening distance, that is the distance between the cornea and iris along a line perpendicular to cornea, a specified distance from the scleral spur, usually it is 250 or 500 microns. And then trabecular iris angle. Angle recess area is the triangular area lying between the line used for angle opening distance, anterior iris surface and the inner corneoscleral wall. Trabecular iris space area is more specific, it gives the filtering area. Other parameters are trabeculo-ciliary process distance, iris ciliary process distance, iris lens contact distance, etc. With angle imaging, the angle is said to be close when there is iridotrabecular contact in more than 2 quadrants. We can evaluate the underlying anatomic and physiological mechanisms for angle closure. 4 mechanisms are involved. They are pupillary block, non-pupillary block including plateau iris and peripheral iris crowding, lens-related causes and retrolenticular cause. In iris Bombay, you can see the anterior converse iris, in pupillary block you can see the iris Bombay, that is the anterior converse iris configuration with the iridolenticular contact over the pupillary area. In plateau iris, it is best identified with UBM. There is anterior rotation of the ciliary process with anterior displacement of the adjacent iris, steep rise of iris root, flat central plane, and absence of ciliary sulcus. That is, ciliary sulcus is the space between the iris and the ciliary process, and there is iridotrabecular contact. Here you can see the cystic space behind the iris. There are non-angle parameters also involved in angle closure. It may be static risk factors or dynamic risk factors. Static risk factors include lens wall, anterior chamber area, volume, iris thickness, area, iris volume, iris curvature. And in dynamic risk factors, we can note the changes in the iris area in response to pupil diameter. Lens wall is the perpendicular distance between the anterior pole of the crystalline lens and the horizontal line joining the 2 scleral spur. Higher the lens wall is an independent risk factor for angle closure. Here you can see volcano-like iris configuration which drapes over the lens, and there is angle crowding. Lens position is the total sum of anterior chamber depth and the half of lens thickness, and relative lens position is lens position by axial length. In primary angle closure eyes, there is more anterior relative lens position and thicker lens. The proximity of the anterior iris surface to the trabecular meshwork is important, and if there is high iris curvature, there is a greater risk of angle closure disease. Anterior chamber width and anterior chamber area are smaller in narrow angle eyes, and the anterior chamber volume is approximately 25% lower in primary angle closure patients. This is a SEPSOS OCT, CSOS2022. It gives 3-dimensional reconstruction of the entire circumference of the anterior chamber angle. It allows to quantify the dimension of iridotrabecular contact, and iridotrabecular index is the percentage of extent of iridotrabecular contact to the whole circumferential distance of the identifiable angle. It is useful in monitoring changes in the peripheral anterior symmetry post-treatment. So in conclusion, anterior segment imaging provides qualitative and quantitative information that helps in identifying mechanisms of angle closure. It is used as an adjunct in clinical decision making. It is useful for long-term follow-up, can be used in situations of corneal pathology, and can help in patient education. Thank you.
Thank you, SMITHA. That was a lot of information and well presented. And now we have Dr. Ronnie, who needs absolutely no introduction to KSOS circles. He works in Shankarnetralaya. He's a big person as far as GSI is concerned, ex-secretary. He was telling us about epidemiology, and he has been involved with landmark studies.
Thank you, Dr. SMITHA, for the invitation, and Thomas for the kind introduction. So I'll basically just run you through the epidemiology of angle closure in India, and those are my, okay. So basically, the information that you have that I'm going to present is from these 6 studies that have been done across the country. And what you're going to see over here is, okay. So the 6 studies that I showed you all basically looked at how many people in a population-based subset had glaucoma. In addition, these 2 studies looked at it longitudinally, what happened to patients over time. And some of the longitudinal data that I'll present will be from these 2 studies. So if you look at the prevalence of angle closure disease, you can see huge variations in the number of PACS that have been reported. If you look at PAC and PACG, those numbers also change. And there are reasons for this, and part of the reason is because between the VES and the other studies, the definitions of angle closure disease changed. Both the studies which were done by trained glaucoma specialists showed significant rates of angle closure suspects. Angle closure glaucoma and PAC numbers are very similar in the other 2 groups. So this is the reason for the difference in the prevalences. So the old prevalence of 4.32% of the Velo Eye survey actually includes PAC and PACG together. And if you combine those 2 numbers for the other 2 studies, you do find that the figures are not all that different. The risk factors in general, what is common to all studies is that with increasing age, the risk of angle closure glaucoma goes up. So in the 70 plus patients, your prevalence is actually as high as 4%. Generally, women were at higher risk because they have slightly smaller axial lengths and hyperopia. And this basically tells you how your axial length impacts the risk of angle closure disease. So this is axial length divided into 10 equal groups from lowest to highest. And you can see that in the shortest axial length group, almost 75% of people have some form of angle closure disease. But what is also important to keep in mind is that even in the longest 10% in the population, about 10% have some form of disease. So you must keep in mind that angle closure can occur at any axial length, but it's much more likely at a small axial length. Anterior chamber depth, as was referred to recently, is also even more closely associated with angle closure disease. And the shortest anterior chamber depth, the 10% with the shortest anterior chamber, almost 90% have angle closure disease. Same situation in the longest hardly 5% have angle closure disease. So you can get angle closure even in somebody who has a long axial length. It's important to do gonioscopy for anybody who's a glaucoma suspect for that reason. And the total number at risk of all this is about 28 million people. And this was the figures that we did for about 2010. Today the number is probably closer to 40 million people. Blindness due to glaucoma, generally angle closure causes more disease because of glaucoma. And we had recently published this meta-analysis where we looked at all population-based studies done globally. And we found that, angle closure causes about 2.8 times as much glaucoma, blindness as open angle glaucoma. And this is something that you need to keep in mind because it is a much more blinding disease, and that the only way you can pick it up is by doing gonioscopy. What about progression? So you have progression studies, you have 2 progression studies. You have the Velo Eye survey, which looked at what happened to PACS and PACS without treatment and PAC with treatment over time. So the Velo Eye survey was first done in 1995. In 2000, the 5-year follow-up was done. So you called back all the patients that you had with PACS and you saw what happened to them. And what happened that 22%, 1 in 5 patients with PACS over 5 years progressed to the next stage of disease. That is, they developed synechiae or they had high pressure, but none developed disc or field changes. What about primary angle closure? These are people who already had either synechiae or high IOPs, but no disc or field changes. 30% of them progressed to primary angle closure glaucoma. The risk was higher in patients who did not have YAG-PI done. But again, none became blind. So both these conditions, you're not seeing a very high rate of blindness over a short time period. What about incidence studies? So an incidence study is basically when you take somebody, you examine them, you rule out disease, and then you follow them up to see whether anybody developed disease over time. So we did the Chennai glaucoma study in 2001, 2002. We followed it up with the Chennai eye disease incidence study 6 years later. And we looked to see how many patients who were gonioscopically open at baseline, how many went on to develop disease. We examined about 8,000 people at the baseline, and then by the time we finally excluded people who had cataract surgery and who passed away and all that, we had about 3,300 people at the 5-year follow-up. And what we found here was that 4% of these people who were normal 5 years ago developed some form of angle closure disease. Most commonly it was PSCS, but some of them did develop PSC too. So these are patients who have been gonioscoped, we think it's open, but they still progress to go on disease. So that's why age is such a large risk factor for angle closure disease. What were the risk factors for people who were normal and went on to develop disease? They had slightly higher IOP. They were more likely to be hyperopic, much more likely to be hyperopic. There was no association with age, gender, or BMI in this cohort. AC depth was very strongly associated with risk of disease, as was axial length, lens thickness, and the absolute and relative lens positions. In fact, if you look at this slide, what you're seeing here is in people who had an axial length of 2.5 mm, 14% of them went on to develop angle closure disease over time. As the axial length became longer, the incidence came down. As the anterior chamber depth became wider, your incidence came down. Lens thickness, again, you see a similar level. Once you had lens thicknesses of over 5 and 5.5, 8 to 10% of patients went on to develop angle closure, which is one of the reasons why the lens vault becomes a problem, because when you have a very bulky lens, you're more likely to close up. In terms of biometry, axial length less than 21 millimeters, 20% chance of progression. AC depth less than 2.5 millimeters, 14%. Lens thickness greater than 5.5%, 10.1%. So these are all patients who had open angles. If you see anybody with parameters like this in your clinic, you know that these are the people who are more likely to develop an issue. The incidence rates for PSCD are actually lower than those reported by other studies from China and Mongolia. And the reason for this is those studies were primarily done in high-risk groups, while this was done in a population which was basically screened and normal at baseline. So what are the other factors? One of the other factors that's really important is that most of the glaucoma that we know is undetected. In glaucoma, in India, 90% of patients with glaucoma were undetected at baseline. And the other common issue that we had was misdiagnosis of PSCG. So what happened is, when you look at patients who are diagnosed to have angle closure in this study and in the Andhra Pradesh eye disease survey, and then we asked back, did you know that you have glaucoma? And we had a few patients in both studies who knew that they had glaucoma. And then we looked at the proportion of people whom we had diagnosed as PSCG, who were being treated as POAG. And what you find is in both these studies, between 60 to 70% of patients with a prior diagnosis of glaucoma actually were being treated as open angle glaucoma when they had angle closure. So if they had had the YAG-PI whenever it was first detected, you could potentially have prevented further progression of disease. So this is, angle closure is a huge problem in India, and these are the estimates that I spoke to you. So in 2020, our estimate is that 46 million people have some form of angle closure disease in India. In 2050, which is not all that far off, 90 million people. So 90 million people is more than the population of about 1/3 of the countries in the world today. And that's the sort of disease numbers we are looking for. So we are sitting on a potential explosion of angle closure disease in India, and we need to be sensitive about it, and we need to look for it. Thank you.
Thank you, Ronnie. As usual, well done. And now you go on to your second talk, management protocol in angle closure disease.
Yeah, so now that I told you that we have a problem, what do we normally do about it? I'm sorry, slide. Yeah. So basically, what is angle closure? And here, there's a fundamental issue here. Angle closure, we think, is mechanical obstruction of the filtering portion, that's a pigmented portion of the trabecular meshwork by the peripheral iris. And clinically, how do we detect it? On gonioscopy, we say if we cannot see the pigmented trabecular meshwork, we assume it's because there is apposition. You cannot see what's going on. And the definition that is now globally accepted is 180 degrees or more. If it is in this configuration, that's primary angle closure. So why don't we treat all patients? I told you that's a huge problem. I told you there are all sorts of issues happening. Why don't we treat all? The reason for this is there's very little data on progression, and I showed you this data on progression just now. The risk of progression of untreated angle closure PSCS was low, 20%. And what does non-visibility on gonioscopy actually mean functionally? It doesn't really mean that they're in close contact. It just means that you cannot see it. If they were in contact, you would be having pigment being deposited in the angle. So non-visibility is a anatomical configuration that predisposes to angle closure glaucoma. It is not pathology at this stage. So that is one of the reasons why we don't really advocate treating everybody with this. It does predispose to angle closure, but it probably does not restrict aqueous filtration, because if it was actually causing decrease in, if it was causing resistance to aqueous outflow, your pressure would increase. And this is what I'm going to show you. These are the numbers of the intraocular pressures of people with PSCS versus normal. And you can see that the numbers are actually not, in the rural population, were statistically significantly different, but in the urban population there was nothing there. And those numbers are not very different. So if the numbers are not very different, then this configuration is probably not doing very much to the eye pressures. So therefore it doesn't really make sense for us to rush in and do something when it is not really indicated. So what are the absolute indications? And the absolute indications are what have been reported by the CGIG and more recently by the GSI, that anybody, the fellow eye of anybody who's had an acute primary angle closure attack, because the other indication is somebody with a family history of PSCG, because if you have a family history of PSCG, there's a 4 to 6 times greater risk that you will develop PSCG. So if you see somebody with a narrow angle whose father, brother, sister, somebody has angle closure glaucoma, go ahead and do the YAG-PI even if there's no other risk factor. The relative indications are somebody who requires repeated pupillary dilatations, and this is with a huge number of diabetics. They form actually the single largest cohort of PSCS that you do a YAG-PI for. People with poor access to care, somebody in a remote village somewhere who may never come back, yes. One-eyed patients are again a relative indication for me to do a iridotomy for them. So even though we don't advocate YAG-PI for everybody, everybody needs follow-up and monitoring, and that is something that needs to be explained to the patient that you have a potential problem, please come in for a checkup. The other very useful thing to tell them is, please ask your family members to have a checkup. Because if you have PSCS, it's very likely that somebody else in the family has some other form of angle closure disease which actually needs treatment. But when you come to PSC, PSC is not only Sinecare and high IOP, but if you have symptoms suggestive of intermittent angle closure, like pupillary rough atrophy, glaucoma flecken, or patchy trabecular meshwork on gonioscopy, or iris atrophy, these are also signs that this patient has had an intermittent attack, and these are patients who you would want to do a laser iridotomy for. So they have no disc or field changes, but there are signs suggestive of a previous intermittent attack or signs suggestive of intermittent apposition. So there's really no question about it. You do a YAG-PI, you reassess the angle and the intraocular pressure you manage medically. So what about if you have an acute primary angle closure attack? I'm not going to go into great details here except to say that you need to control the intraocular pressure, oral acetazolamide, injection mannitol if needed if they're systemically okay, topical steroids, topical anti-glaucoma medications, start the pilocarpine only once IOPs come down. If the IOP has reduced, start the pilocarpine, do a YAG-PI, reassess, look for the disc, field and the angle, and especially gonioscopy in the fellow eye. So in primary angle closure glaucoma, now this is somebody with definite disc or field changes. Raised IOP or peripheral anterior Sinecare are not mandatory for the diagnosis. So here what is the situation? You do the YAG-PI, you reassess the angle, and intraocular pressure is treated medically and if required surgically. So the angle control you need to reassess. The story doesn't end when you do the YAG-PI. The story ends when you see what has happened after the YAG-PI. And in general, you would want to do the gonioscopy at least 72 hours after you have done the YAG-PI, because the pilocarpine effect has to go off for you to see what is happening to the angle and whether it's still occludable. Keep in mind that you can have a Plato iris configuration in any phase of the disease. And about 25% of angles post LPI will not open up. And that can happen in PSCS, PSC or PSCG. And that's why it's really, really important to do a gonioscopy post YAG-PI. And a Plato iris configuration typically looks like this with the double hump sign. So when you have Plato iris, what can you do to open up the angle? Because it is blocked because you have a bulky iris process sitting there. So what can you do to open up the peripheral iris? One thing that you can do is try pilocarpine. I typically would give pilocarpine once a day at night, and that is sometimes enough to just open up the angle. The other thing that you can do is iridoplasty, which I'll talk about a little later, or you can consider early cataract surgery in these patients. You can also observe them if they are, amenable to follow up. You can observe them closely to see whether there's any progressive change in the angle, but here it becomes very important for you to document what you're seeing in the angle and look closely for any Sinecare to form. So in iridoplasty, essentially you use a argon or a frequency double YAG to just put these spots in the periphery, and that causes constriction of the iris around it and pulls the angle open. And this is what it looks like on UBM. So you can see that this angle is fairly narrow there, and here post iridoplasty that peripheral iris has flattened out and the entry to the angle is open. The concern basically has been that in the long term it doesn't seem to really keep the angles that open, and which is why we don't do it that often. So the general impression is the long-term effects are not that good. And I'd like to share with you the last few slides. This is the management algorithms for primary angle closure disease done by Dr. Ravi Thomas, who's one of the stalwarts of angle closure research in India, globally. And so basically what he's telling you here is angle closure is quite easy. Do laser iridotomy. If the angles open less than 180 degrees and the patient is uncontrolled on medical treatment with sine K less than 180 degrees and a cataract, go ahead with the cataract. If there's no cataract, try a laser iridoplasty. If that doesn't help, then you may need to do a trabeculectomy if they progress to PSCG or IOPs, or the IOPs are not really controlled. If the angles open more than 180 degrees, manage it as an open angle. If the angles open less than 180 and controlled on medical treatment, if there is visually significant cataract, you might want to think about it. If there are no visually significant cataract, you can just hold on to it. If on indentation you have extensive PAs and the intraocular pressures are uncontrolled, if there is a cataract, consider doing a phacotrabeculectomy. If there is no cataract, again follow up, consider doing a trabeculectomy if the intraocular pressures are uncontrolled. So this is a fairly logical and sensible conservative way of managing angle closure glaucoma. So in the management of PSCD, not all eyes need treatment, but careful gonioscopy is required by all eyes, both at diagnosis and follow-up as necessary. Thank you.
Thank you, sir. That was an excellent presentation. Now it's my pleasure to introduce Dr. Girija K, who is Senior Consultant and Head of the Department of Glaucoma in Little Flora Hospital. She'll be speaking on surgical treatment of angle closure disease and a very interesting topic of role of early cataract extraction in glaucoma patients.
Good morning, everyone. Surgical treatment of angle closure glaucoma and role of early cataract extraction. So, as all of you know, the PSEG is a leading cause of blindness and it's more prevalent in Asia. So, the treatment options available are lasers primarily. So, initially we treat all the cases with occludable angles where there is more chance of progression. We always consider laser and the surgery comes later only. So, what are the indications of surgical treatment? When the eye has been treated with lasers and medical treatment is being continued because the IOP is uncontrolled, but the glaucoma is progressing. And when the angle closure or the pass is progressing despite a successful LPI, and when the patient is showing a poor compliance to the medical treatment, or when patients cannot cooperate for the laser treatment, you have to think of surgery. So what are the if LPI is not possible, then you have to think about surgical iridectomy in certain situations. That is an acute angle closure glaucoma patient when there is unresolved corneal edema, but the patient is, the IOP is not at all controlled, or if an uncooperative patient for glaucoma, then non-availability of lasers in the center, corneal opacification limiting the view of the anterior chamber. Then in certain post-retina surgery patients, even if you do laser iridotomy, it keeps on closing. So you may have to repeat it multiple times. So in that case, you can consider a large surgical iridectomy. Then it can be combined with other surgical procedures like trabeculectomy, phakic IOLs, DSEC, all these procedures. When, in order to prevent pupillary block, you can do a surgical iridectomy. Then along with biopsy of iris or ciliary body lesions and optical iridectomy. So after surgical iridectomy, the next option is a goniosynoculolysis. It's not very frequently done. It is usually, it can be performed along with the cataract extraction where you can mechanically strip the pass away from the trabecular mesh using viscoelastics or an irrigation cyclodialysis patella. But usually I've seen that it is not very effective because the synechiae formation recurs, because the inflammation is still there and the synechiae reforms. Then GDD in very chronic angle closure glaucoma with failed trabeculectomy, but in an angle closure glaucoma again the risk is more because the limited space is there, so the tube can get occluded with iris, or you can get corneal decompensation because the space is very less. Then in angle closure glaucoma eyes with end-stage disease, if the patient is symptomatic with a poor visual potential, you can consider CPC. So trabeculectomy is the usual surgical treatment for an angle closure glaucoma, which is uncontrolled with medical treatment and status post LPI. So the procedure, the steps are the same as in open angle glaucoma, but one thing you have to be sure is that you do a surgical iridectomy here in order to prevent postoperative complications like malignant glaucoma, because nowadays the tendency is to avoid an iridectomy along with the trabeculectomy. So, but in an angle closure glaucoma, always do an iridectomy, and always it's better to use intraoperative mitomycin because these eyes will have a low grade inflammation and the chances of failure of trabeculectomy is more. Suppose the patient is having glaucoma and cataract, then whether to do a phaco trab or a phaco alone, the debate is there, and you have to consider, I think Dr. Roni has explained to you, the angle closure glaucoma which is status post LPI, but with the cataract, with a controlled IOP, you can do a phaco alone. But uncontrolled IOP, you can either do a phaco trab, but suppose the IOP is very high, then it's better to do a trab than follow it with a phaco. Without cataract, with a controlled IOP, you can continue the medications. And uncontrolled IOP, without cataract, again you can do trab or a clear lens extraction. But in controlled IOP, if the patient is on maximum medications, it's always better to do a phaco trab. Risk factors are, again, Dr. Roni has mentioned them, the aging changes, like an increase in thickness, increase in the lens vault, the weakening of zonules, then changes in the iris features. All this will lead to a shallowing of the anterior chamber, increase the iridotrabecular contact and pupillary block, and it will block the aqueous outflow. So when you do a lens extraction, it will relieve the pupillary block, it will deepen the anterior chamber, it may separate the PAS, and it will increase the outflow. Along with that, it will increase the visual acuity also. So these are it's a meta-analysis of 5 randomized control trials comparing phaco emulsification versus phaco trab in PACG. So it was found that a consistently greater IOP lowering effect was seen in phaco trab, and lower number of AGMs were needed postoperatively, but risk of complications was higher when you combine a trab with a phaco. This is another meta-analysis where 16 eligible trials were included, 5 randomized control and 11 non-randomized, and the patient sample size was very large. It found that the IOP control is greatest for phaco trab, followed by trab and then phaco. But the deepening of the anterior chamber depth was there whenever you do a cataract extraction. Along with that, the visual acuity also improved when you did the cataract extraction, but the outflow facility increased in all 3 and the surgery success rate was similar. So phaco trab was found to be superior than the other 2 surgeries in IOP control, the chamber depth, visual acuity and adjunctive therapy, but trab is superior than phaco, not phaco trab, in IOP control, but it had more complications. Now coming to the role of lens extraction. It can be a clear lens extraction or an early cataract lens extraction. So first I will mention the EAGLE study. It's a randomized controlled trial which compared the efficacy, safety and cost effectiveness of clear lens extraction versus LPI as the first line treatment of primary angle closure glaucoma, angle closure and angle closure glaucoma. The patients 50 years or older with no cataract and IOP more than 30 millimeters with PAC or PACG was included. 419 patients included, 208 underwent clear lens extraction and 211 underwent standard care with laser iridotomy. 36 months after treatment, it was found that the mean IOP was 1.18 millimeters lower in the lens extraction group, and the quality of life according to the QOL 5D questionnaire was greater, and it was also found to be cost effective. These are all various studies comparing it or doing a cataract clear lens extraction alone for increase for angle closure glaucoma. So how does the IOP rise? Intraoperative mechanisms. So injection of viscoelastic, the force fluids, increasing the hydrostatic pressure, the lens extraction, putting the IOL in the bag, all these will deepen the anterior chamber, it will open the pass and it will open the trabecular meshwork and increase the outflow. Along with that, the release of prostaglandins, interleukins, etc. also play a role. The clear lens extraction will relieve the pupillary block and it will also remove the plateau iris component. So what is the effect of cataract surgery on intraocular pressure reduction? There is a reduction of 1.5 to 3.5 millimeters over a period of 1 month to 3 years in normotensive eyes. But the reduction has a linear correlation with preoperative IOP. If the IOP is more, then the IOP, post-operative IOP reduction was also found to be more. This was supported by the Matsumura et al. Study and also the ORT study. So the pros and cons of clear lens extraction is that it was based on the low surgical complications, but always remember the unforeseen complications like PCR, malignant glaucoma, etc. Always the short eyes with narrow angles present challenges to the surgeon due to all the anatomical peculiarities, but take thorough precautions, do a thorough preoperative workup, use OVDs and prevent anterior chamber collapse, and always tamponade the anterior bulging curvature of the capsule before doing rexus. Always take care that a hydrodissection is not forceful, because it can lead to a blowout of the posterior capsule, and take all the due precautions and you can prevent the complications. But the question remains, can we advocate a primary role of cataract surgery in eyes with glaucoma over the entire glaucoma spectrum? So is clear lens extraction a solution for angle closure glaucoma? The debate continues. Thank you.
Thank you, ma'am. Thank you, ma'am. We can take up the questions.
Girija, the message should not go out that clear lens has to come out. That is absolutely clear from us, glaucoma. Though we know that getting rid of the lens and putting an IOL which is thinner would give us space. We knew it all along. There are studies on lens vault, and the Eagle study, it has got a lot of flaws in the study. I'll let Ronnie go on it. He is an expert on the flaws of the study. It is basically a marketing of clear lens extraction that has happened. The study itself, not all patients have been gonioscoped. That's probably the biggest flaw for me. And if there is any symptom of cataract, go ahead, do a cataract surgery. A symptom attributable to cataract. Our lenses, IOLs, are still not perfect. We are still finding out newer, higher order aberrations. So we cannot give them the vision they had with their own clear lens. Plus, when you're looking at an anterior chamber which is 0.5 millimeters, your phaco probe has to get in there and work. It's not for the run-of-the-mill surgeon. I take probably 2-3 times the time I take for a hard brown cataract for doing one of these early cataracts in angle closure.
That is why I put the topic as not clear lens extraction but early cataract extraction. Because suppose that the angle is, the anterior chamber is very shallow and the patient has an early cataract, you can go in for this thing if there is PAS formation, beginning of PAS formation. Never a clear lens. I don't support clear lens extraction. Because as Thomas has said, it is difficult when you do phaco in an early cataract, it's very difficult. If a clear lens extraction, not an early cataract, yeah, especially in an angle closure, because you are subjecting the patient to an unnecessary procedure. So I have mentioned all the anatomical peculiarities, the shallow AC and the limited surgical space. So always use OVDs whenever you are doing a cataract extraction in an angle closure eye, because that will give you adequate space to work in. While doing a capsulorhexis, and also at the end of the procedure when you remove all the cannulae, everything, you have to fill the AC with OVDs so that the anterior chamber collapse is prevented, and you can also intraoperative choroidal effusions are prevented. Any questions?
I think you covered everything very comprehensively. And just, I think what's really important is that gonioscopy has to be done more often. Yesterday there was a paper in the pre-paper session where they looked at the number of patients who were referred with their workup done, and 90% did not have gonioscopy done, even in this day and age. It was the same story when we looked at it 10 years back. So I think the young people in the audience have to learn how to do gonioscopy and have to do it, because you're going to see more and more of this. Unless you learn how to diagnose and treat this properly, you will be wondering why that cataract surgery went bad, why this patient with POAG is progressing. Part of it is related to this, just that we miss angle closure disease.
And getting an OCT machine into the hospital and sending it to the optometrist to do an OCT and give us a printout sounds very easy. But then, like any CT report and MRI report, there's a footnote at the bottom, correlate clinically, and the only clinical correlation is your clinical gonioscopy, and there is a big soft skill. You need to do gonioscopy for years to be really confident. So please start and do regularly. See all the normals, then you start seeing the abnormals being picked up.
And as Dr. Lita has said, keep doing it, because even if you have diagnosed, you have done an LPI, but still do it during every follow-up, because angle closure disease does not stop at LPI, so it progresses. It's a progressive disorder, so every review, at least once a year, you have to repeat your gonios.
Which gonioscope? Single mirror or two mirror for beginners?
Both the single and the two mirror are the lenses which need coupling agents. And the only thing is single mirror, you have to keep rotating it a lot more. Two mirror is more convenient. Slightly more expensive, but it's worth it. You need to rotate only 90 degrees, other one you have to rotate 360 degrees to see all of the angle. Those would be preferred over four mirrors as a starter, because they act as a speculum. You can manage with slightly uncomfortable, uncooperative patients, and there is certain amount of suction that it doesn't come off. The four mirror tends to just slide off the hill. So it's easier to get the image in the two mirrors. Learn with the two mirror, then we can graduate onto the four mirror. A two mirror, the gonioscopy basically is, to start with, is a little confusing because of the lateral inversion. It's just the same way as you look into a mirror to comb your hair or whatever. The person in the mirror, the right, what looks like the right is actually the left. That's all you need to remember. What you see at 1 o'clock is at 5 o'clock, and not diametrically opposite at 7 o'clock. That's all you need to know. Front and back are the same, so it's not confusing.
To always explain to the patient before putting the lens. For the beginners, it's a very important point. Otherwise, patients suddenly get scared and they squeeze the eyes. So even if after some years also, you should explain to the patient, I'm doing such and such a thing, or you can ask your assistant to explain.
I think the time is over, and we'll wind up the session and give way for the next session. Okay, thank you very much for your patient hearing.